Hi guys, my name is Sierra Payton and I'll be doing postpartum C-section care. So a C-section is a major surgery. So the same things apply for a regular surgery. So we're going to want to make sure that the woman is NPO, nothing by mouth, for at least 8 hours before the operation. But we know that a cesarean section can also be performed as an emergency. So they may not have time and they may have eaten. But other than that, it is usually NPO. You want to make sure you get an informed consent before the procedure, and even before they do the surgery, they're going to have a timeout where the circulating nurse looks for this paper in the file to make sure that it has been signed. Before the surgery, you want to make sure you get a complete blood cell count and a blood type and RH status on the mother so that you know what you're dealing with, and if she is RH positive or RH negative, what you do then. You're going to watch and monitor the maternal vital signs and the fetal heart rate just to make sure that they're doing okay. You're going to give them fluids. You're going to keep them hydrated. And this is just in case you have a line open if an emergency occurs. Usually at this time before the surgery, they can insert a Foley just so that, because once she has the surgery and the epidural, she's not going to be able to feel anything. So she's not going to be able to know if she's voiding or not. They usually put TED holes or SCD boots on them so that they prevent a blood clot. You want to teach the woman about post-operative expectations, like the pain that she's going to be feeling afterwards, how to change positions, coughing, deep breathing measures to subside her pain. Now, intraoperative care. You're going to position the mother so that the uterus is displaced laterally so that they're not compressing the inferior vena cava. And we know that when a woman lays on her back, she's compressing this inferior vena cava, which is not allowing the fetus to get enough perfusion. So they're going to put a wedge under the hip to tilt the table to one side. She also may be anxious about the sensation she's experiencing, especially if this is her first time. So as a nurse, you want to make sure you're telling her exactly what's going on so that she's informed. Infants are considered to be at risk until evidence of physiologic stability after birth is observed. So you're going to have a resuscitation team there that is trained to see if the baby is doing okay or if the baby's having problems, and then how to fix it. And if everything's okay, the baby will go to the nursery. If not, it will go to the neonatal intensive care unit. So the immediate post-operative care. Once the surgery is completed, the mother is transferred straight to the post-anesthesia recovery room. And this is where they're going to make sure she has a patent airway. She's positioned to prevent possible aspiration. They're going to check her blood pressure and her pulse every 15 minutes for the first 2 hours. Because in that 2-hour block, if something occurs, they will know it in enough time to change the situation. They're going to check her temperature every 4 hours for the first 8 hours, and then after that, it's every 8 hours. And this is basically for a sign of infection. They're going to check the condition of the incision dressing and the fundus and the amount of blood that she's bleeding after the fact. And they're going to check her urine output. Now, we talked about this in class today. Oxytocin is usually added to the first liter of IV infusion to ensure that the fundus remains firmly contracted to reduce the blood loss. And because she did not have a vaginal birth, her body may not or will not produce that oxytocin. So the woman is assisted to deep breathe, cough, turn, and perform leg exercises so that she just to get her body moving again. They're going to give her medications for pain relief, and you want to make sure you're doing this before it's time. I know it may be every 4 hours, but you want to make sure she's getting it at the exact time because you don't want to wait till the pain gets too bad. The mother is discharged from the post-anesthesia recovery room only when anesthesia has subsided. She's alert and oriented, her vitals are stable, and she's able to move her extremities. So here's just a little thing I found in the book, and it's basically teaching for non-pharmacological pain relief. So you want to splint the incision, and that's basically where you can get a pillow, put it up against the abdomen, and then cough or moving so that you have some type of guard to keep that you're pushing against. So it makes coughing less difficult. You can use relaxation techniques like breathing, dim lights, just getting in a relaxed mood. Because she did have a major surgery in her abdomen, she's going to have gas. So you want to get her up and ambulating. You don't want her to drink any gas-forming foods, beverages like soda, or carbonated drinks, basically soda. Don't use straws because you're going to intake air when you're sucking through a straw, which is going to make her gas worse. You can give her gas meds, pills to basically expel the gas, or she can lie on her left side, or also rock in a rocking chair. Now, certain things that we need to make sure before you palpate the fundus or massage it, make sure she has her pain meds because this is going to be extremely painful for her. Now this is a couple of days after, or usually like the 24 hours after. As caregivers, we should stress that the mother is a new mom first and a surgical patient second. So this helps her understand her role and her identity as a mom, and that she will still have the same issues as a mom that delivered vaginally. Now, usually, depending on what hospital you're at, they'll allow the mother to eat right after, or some doctors may say NPO until her bowel sounds return. But the mother usually knows if she's able to eat or not. Then by this time, they're going to switch to PO meds. Now, some nursing interventions is we want to make sure she's getting enough sleep and rest because she just had a surgery. You want to make sure she's doing hygienic care. That means breast care, taking a bath only when her dressing has been changed. Once it's been on, the new dressing has been taken off. We usually take the Foley out and we encourage them to get up and walk around and as void as soon as it's taken out to make sure that everything is working properly. The nurse is going to assess the woman's vital signs like we talked about, the incision, the fundus, and the amount of bleeding she's having. They're going to check her breath sounds, her bowel sounds, circulatory status, everything you would do post-surgical. It is important to observe maternal emotional status as well. Guys, please do not forget that her hormones are raging. They're up and down. We want to make sure that we are attending to her emotional needs as well. Now, when a woman is still on those analgesics, she still may want to breastfeed. And if so, you need to make sure that somebody's in there with her because she can become drowsy or even falling asleep while holding this baby because of the drug she's on. Now, discharge information. Basically, a mother is usually discharged around day 3. But it just depends on the hospital policy. And the bad thing is, they're not really discharging them when they are physically ready. It's usually according to the insurance or the policy of the hospital. Now, some things you want to talk about when you're discharging the mother: nutrition, pain management, rest, contraception, when is it okay to resume sexual activity, baby blues, breast care, all of these things you need to talk to the mother about. Now, the biggest thing is teaching her signs of complications after the birth. If she's left and went home, how can she know that something is not right? Well, her temperature is greater than 100.4. That is going to be on the test, guys. She said it. Make sure you know the temperature. If she's having painful urination, urgency, or cloudy urine, she may have a UTI. Something could be going on. Now, her blood, if it's heavier than normal menstrual period, clots, odor, like she said, if she's wetting up a pad within 15 minutes, she's probably hemorrhaging, and you need to have her come back to the hospital as soon as possible. Now, for the incision, check for redness, swelling, bruising, foul-smelling discharge, all of those things. If she's having severe abdominal pain, she needs to come back to the hospital. And this is going to be a video of a live C-section. So check it out, guys. It's really, really cool. Thank you.